Next, moving right along, we have Justin Saliman, our gold sponsor, whoop whoop, CEO of OutcomeMD and keynote speaker of the day, who will be sharing his thoughts on the future of health outcomes, not opinions. Justin will shed light on what the future holds for the healthcare ecosystem. The session will center on the idea that healthcare should be more individualized based on the person's requirements rather than being a one-size-fits-all, and more preventative than reactionary. Join me in welcoming Justin up on stage with a huge round of applause.
I think they're queuing up the slide deck here. I am Justin Saliman. I'm an orthopedic surgeon by training. After fellowship, I pretty much just started companies, several of them, some in the surgical device world, OutcomeMD's in the SaaS world, and PaaS world, platform as a service. And so I'm going to just talk a little bit about why it's just so critical that we shift the way we're thinking about what we're doing and focus on what really matters. We need to measure what matters, and that is a patient's symptoms and quality of life and how they change as a result of our treatments. So you say, well, how do you do that? The medical literature actually has this all figured out for us. We just follow what they do. Enroll every single patient into a clinical study without consenting them for research. And you can do that because there are these things called patient-reported outcome measures that already exist. They've been built over the last 130 years by specialists in every specialty in medicine, because everything's been studied. And they came up with question sets and scoring formulas for how to measure a patient's symptoms and quality of life burden over time and see how they change. It's decision support from day one to score their symptoms and decision support throughout the journey to keep track of how they change. This is objective. And the reason it's objective is because these question sets have been validated and compared against other ways to determine an outcome. How has the MRI changed? How the lab values changed? How has the physical exam changed? And if they don't statistically significantly correlate with how these things change over time, then they're thrown out and they write new ones. So they're validated is the point, and they're objective. And I argue that they are the most, and it's not just me, they're probably the most important measure of how someone does over time. And the reason, I'll give you an example. So I'm an orthopedic surgeon by training, but OutcomeMD works across every specialty. But I give orthopedic examples. So imagine you have hand surgery, and on X-ray and MRI, it looks perfect. Complete healing, no edema in the bone, really good result. On physical exam, patient has full range of motion. Seems like a pretty good outcome. But let's say that every single time they touch something and every time they move their hand, they have searing, burning pain. It's actually a pretty lousy outcome. So how have the patient's symptoms and quality of life burden changed as a result of their treatment is the most important outcome. Look around, there are people everywhere. There's results everywhere. We just don't keep track of any of them. And I'm going to show you throughout this presentation how if we just make this shift to keeping track of this stuff, yeah, sure, value-based care is, of course, completely hinges on knowing what works and what doesn't work. But you'll also see how the fee-for-service world also benefits from this kind of a technique. So a couple of other background things. We should be doing this, like you use a stethoscope on every single patient, maybe, or you do a physical exam on every patient. How is it possible that we don't measure a patient's symptoms and quality of life burden since there's a way to objectively do it? The patient walks into a room, the average doctor interrupts that patient after 11 seconds. Okay, this is from Journal of General Internal Medicine a couple years ago. 11 seconds, and at first it's like, are you kidding me? That's horrible. And then I thought about it. No, we really do. The patients will go off on this crazy story about how their dog and this thing, and like, that's not helping you make a medical decision. You try to bring them back into the lane where you need to document in order to get paid for this visit and also try and make an efficient decision so you're not spending 2 hours with the patient, right? So we really don't have time to fully assess the patients. And the truth is we haven't memorized the perfect questions to ask a patient. We ask whatever random 3 or 4 questions we think of to assess their symptoms, even though the validated perfect questions are there in the medical literature. But it's ridiculous to think that we should be memorizing them. We certainly can't memorize the scoring formulas and do that quickly in our head, right? So we just don't do it. It's more gestalt-based, right? But we really should be doing this on every patient. And the data that comes from this is jaw-dropping. So if you look at electronic medical records, we built these things 35, 40 years ago because, one, because it's a good billing system, but two, because we thought the big data, it's gonna cure disease, right? And it's done nothing but really piss doctors off. And then about 10 years later, correlation algorithms started to come out, and IBM makes Watson, and that too did nothing but piss doctors off. Epic made a decision support tool, and they had to pull it from the market. It was actually hurting people. And the question is why? Why have electronic medical records and correlation algorithms not cured disease? And the answer is that there's no outcome data. There's no outcome data anywhere in the electronic medical record system or our system at all. Yes, you can mine infection rates, rehospitalization rates, length of stay, number of procedures done, but that's all sort of inferred metrics. And star ratings are the worst thing to possibly go by. It is tearing down our healthcare system, turning every doctor-patient interaction into an era of blackmail, right? We patient cater, we don't patient care, because my business model is dependent on making you satisfied. If we have this data, though, everything changes. I just want to, let me go back. I want to play this piece of audio because this is interesting. So this is a NPR gentleman who's interviewing a Kaiser executive and asking her, why have electronic medical records and correlation algorithms not cured disease? And her answer is very interesting.
That's pretty bare bones information. Ideally, these medical records would provide a much fuller picture of a patient's emotional state. But Lou says that would require more work for the patients.
If you're a patient and someone says, gee, we'd like you to fill out this 30-item survey on a routine basis, you're going to say, why? What will this get me? How will it help my care?
That's one of the many problems researchers will have to solve in order to make these electronic medical records deeply useful in a world that straddles research and practical information.
So basically, what she's saying is that patients don't want surveys. Of course they don't, right? And especially if there's no meaning behind them. Patients will do things for two reasons. One, it's interesting to them, so you got to figure out how to do that. And two, the doctor is saying, I need this information in order to figure out how best to treat you. Those two things added together, and they will do it, and we've proven that, okay? So what we've done is turn these patient-reported outcome measures from the medical literature into a fitness tracker-like experience for the patient, and then created a billion incentives around it for the doctor to the point where they really want the patient to do this because they're making more money as a result. So the first part of this looks like this. So the patient gets a text message. There's no app to put on the phone. There's no username or password. They just click a link, right? And when they click the link, they just put in their date of birth. It shows a little animation so the patient has a sense for what's going on and that this is going to help them keep track of how they improve over time. And then it just asks for their date of birth. It's all white labeled. This is API based, or you can use the software as a service either way. So it can really feel like your own user interface. And the patient quickly measures their symptoms either with your existing survey engine or with our survey engine. And then we do some cool stuff around the scoring so that if you want the patient to see their result, turn it into fitness tracker-like experience, we can take that raw data and turn it into a scorecard for them. It takes about 3 or 4 minutes for a patient to complete this. 97% of patients that start an assessment finish an assessment, okay? And they get to see their score. And then there's a timeline on this page, there's all sorts of cool stuff. When they are doing better, it animates like the, oh, I'm sorry, so let me go back. So this is their starting point score, all right? Now, 3 months later, or whatever it is, after they've taken their medicine for a little bit that you prescribed, they've done the therapy that you suggested, or they've had surgery, whatever the treatment, or benign neglect, whatever the decision that was made was a treatment decision or a non-treatment decision, right? But a decision of how to handle this person's medical problems. 3 months later, they're sitting on their couch. And they get a text, and it says your previous score was a 30. Let's see how you're doing now. They just have to be curious. You know, when you go for a jog, you're curious about how many steps you took. How far did you run? What was your heart rate, right? So we're just playing on that curiosity. They remember that it was easy. There's no app, there's no username or password, and it took just a few minutes. So they click the link, and they answer the questions again after they put in their date of birth, and they get to see how their scores improved, right? And thinking how a patient thinks, of the improvable range, how much have I achieved, right? So their score was a 30 in February. Now they've improved to a 73, and of the range they could get better, they've achieved 61% of it. This engages the patients and makes it interesting to them, okay? and the doctor wants them to do it for all sorts of reasons I'll show you in a second. If the patient's getting worse, it animates like this. And they're not surprised, they feel worse, right? And 1 second later after this animates, their phone rings. Well, who's on the phone? That's the doctor's office calling to check in on them, right? So now this is true connected care. Now how does that work? Well, as soon as they answer the last question, the math is done very quickly on the servers, and we instantly text and email whomever on your team you want at different thresholds, okay? For example, and we empathize with the providers all the way through. So I never want to be notified for an eczema patient who's doing poorly and getting worse, right? Because who really cares? But for an angina patient who is post-MI, is on these 3 medicines, is in this age range, you know, I want to be notified if they're doing poorly and getting worse below a 10. And I want my PA to be notified if they're doing poorly and getting worse below a 50. So it's really easy to set that stuff up within the software, okay? So as soon as the patient sees this animation and they're within the bad threshold, right? They're doing poorly and getting worse, the PA or MA or doctor themselves gets this message text to them. There's no PHI in it, but it gives you a sense for who, you know, it's this age patient and they were assessed for this problem and this is what their score is doing. And when you click the link, you Face ID into our iOS app. So now you can, in a HIPAA compliant manner, see this patient's information and what's going on with them, okay? And you can call them with caller ID blocked, the way I like to call my patients, right? So they're not texting you a minute later. This is true connected care. Now, if patients are doing great, they love you. And if patients are doing crappy, they love you because you care enough to check in on them and to intervene, right? And this has been shown to reduce readmissions. It's been shown to reduce complications. Here's a study in the Journal of General Oncology. Journal of Clinical Oncology. They basically, there's 2 cohorts of cancer patients, identical in every single way. The only difference between the 2 cohorts is that in one cohort, they actually tracked 12 symptoms of cancer complications, basically, and the other they didn't. So they had a PRO of 12 questions, a validated PRO. And when someone was doing poorly and getting worse, a nurse was notified and intervened. Those patients, the only difference was that they were sent PROs, and a nurse got notified if they were doing poorly and called them. They lived 5 months longer. It was a big sample size. So there's lots of studies like this. So beyond the fact that the data is the most valuable data in the world and can really cure disease and really cure the American healthcare crisis, it also has applications to clinical care right now that are pretty profound. We also give this timeline visualization of care. When you think about it, every single thing you need to know about a patient can be shown on one timeline. Their entire past, every single endpoint from the EHR dropped on a timeline as a flag. All the medications, procedures, diagnoses that they've been through are in the EHR. They're plotted out. And then everything that's in the future is also plotted out, right? But what a patient really cares about is what are the things that I've been through that have resulted in my improvement in symptoms or worsening in symptoms. So this adds to the fitness tracker-like experience. It's integrated with the medical record system to the point where it pulls in the endpoints, and the patients can add things that they'd like to track. Oh, I'm starting a keto diet. Boom. Shows up on the doctor side and the patient side. The right side is the patient, the left side is the doctor. And they build this timeline together, unified as one with a united goal of getting improvement in symptoms. Every time, it's even possible to be able to click a V icon on the bottom of the graph, which is a visit, and see a PDF of the note from that day, and there's your physical exam. So pretty much everything you care about is here. The other thing we track are confounding factors. These also plot out here. So when you see lost and changed jobs on this timeline, that's an example of a confounding factor. We track adverse life events and stresses, social determinants of health, new injuries. I'll explain new injuries in a second. Patient compliance. With every follow-up, we ask patients, how closely did you follow your doctor's treatment plan? And we ask that, and then they rate it out of 10. And since it's their own fitness tracker-like experience, we're seeing people rate 4 all the time. If they didn't take the medicine, they're not going to get a good result. If they weren't non-weight bearing, maybe they're not going to get a good result. Like if they weren't compliant with the doctor's treatment plan. And then on the example that I like to give is if I replace your right hip, and 6 months later you break your right ankle, your function is down and your pain is up. And it's not because I didn't do a good hip replacement, it's because you broke your ankle, right? And so we need to be able to create an inclusion and an exclusion criteria around all of the things that make this feel fair. And if it doesn't feel fair, a doctor's not going to use it. Inclusion and exclusion criteria are what you do in an FDA study or clinical trial. So is it ethical to think about it that way? Yes, that's the right way to think about it. And then there's also a dashboard where you can dial in best practices to know what works and what doesn't work. It's filterable all the way from the top. Let me just, on the dashboard, this kind of thing is where you really can figure out what protocol works best, which medication works best in your hands. And it shows you in real time your outcomes. And it's not just those that you enrolled in research, it's every single patient that walks through the door. The key to value-based care, by the way, is being able to dial in best practices. And the key to being able to dial in best practices is having outcome data, and none of us are doing it. It's crazy. Okay, so that's everything I've shown you so far is elevate. We say you should elevate and celebrate your outcomes. Don't just elevate. That means tracking outcomes actually improves outcomes. I think we've talked about that enough. Now I'm going to talk about how you can celebrate your outcomes, right? This is shifting the doctor's business model from patient catering to patient care. Every great outcome, we should be celebrated. And so the way this works, we did a lot of studying, and we found that patients who achieve at least 50% of their improvable range love their doctors. They're bringing you a box of chocolates and a bottle of scotch, right? And so when we see a patient has achieved 50% of their improvable range, then and only then they see a pop-up that allows them to endorse their doctor by posting their great results on their own social media or on the doctor's review sites. When it goes on their own social media, it looks like this. The average Facebook user has 338 friends. When one of their friends sees this post and click it, it goes to the doctor's website. This is also a cathartic event for patients. We have use across every specialty, but the one that I'm shocked by is the ketamine clinics. Their patients are posting left and right that their PTSD and anxiety and depression are better. If you think about it, their network, their friends, they know that they're struggling with these problems, and this is a moment for the patient to say, hey, I'm better, you know? And it also celebrates the doctor at the same time. So that's lead generation, and then we also copy into the clipboard. If the patient chooses to not post on social media and they'd rather post on their own review site, on the doctor's review sites, we copy into the clipboard a summary of how the score has changed, and we take them to that doctor's review site to post it. And so this is a real one on Yelp. My knee symptom score was 20 before, and my score's improved to 91 so far. Thank you so much, Dr. Kabai. Pushing objective score data into a subjective review site for the first time in the history of medicine, and this is a more impactful post. And there are a bunch of other ways that I'm not going to get into today where we drive value, marketing value, from these posts. Celebrate your outcomes. Outcome marketing is what we should be focused on. Get great outcomes, and that generates more business. If you think about the data, you know, you're enrolling every patient in a clinical trial, but you're doing it for clinical care. You're doing it for decision support from day one, decision support throughout the patient journey. You're doing it for a timeline visualization of care. You're doing it to be notified when someone's doing poorly and getting worse. For all these reasons, it's for clinical care. So this is a normal IRB process when you're trying to prove something works or write a study. And this is the process when you're tracking outcomes for clinical care. The IRB views it as a chart review. So you can actually look in the dashboard and see what's working and what's not working. Turn on inclusion and exclusion criteria around all of the medical record data, all of the confounding factor data, and the patient-reported outcome data. Figure out what's working and write a paper on it by clicking one button, export, done. Send it to the IRB. They say, oh, approved, chart review. You don't have to consent patients for research, and the sample size is huge because everyone's enrolled. What are the things that are missing? 2 things are stuck in the patient's brain. How have their symptoms changed over time and quality of life, and confounding factors? Gotta structure data around both of those things, and we change the game in healthcare. This is a cool thing that's coming. So decision support tools, I said before, didn't work. Watson's BS. But if you have outcome data, all of a sudden, it's incredible. So the EHR, electronic medical records, health records, they know the patient's phenotype. That's the one thing an EHR is pretty good at, is what's this patient's phenotype? What's their age, gender, body mass index, race, medical comorbidities, zip code? Like, you know, who is this patient, right? And then Outcome Warehouse, like what we have, has results from patients similar to this one all over the world, right? So normally, before a software like this, maybe you put them on drug B because for whatever reason, they have a nicer drug rep, or for whatever stupid reason we make decisions, right? But now, in front of the patient, you can flip around your screen and say, look, drug A or drug B, let's figure this out together, right? And click a button in the EHR and plot it out. Each dot is a different de-identified patient somewhere else in the world who's phenotypically similar to the one sitting in front of you. Full wellness is 100, right? Full function, no pain is 100. So I'm going to put this patient on the blue on the purple drug, right? Drug A. And the network effect here is crazy. What is this? This is an instant, prospective, multi-center, randomized controlled trial done on phenotypically similar patients at the point of care with enormous power. It's not what 30 patients did they study in Kansas. It's 30,000 patients from all over the world who are phenotypically similar to the one sitting in front of you, right? I mean, this is what we should be doing. It's only an art of medicine because there's not enough science, right? And then finally, here's how we cure disease. And this is the future of medicine. So, at first I thought it was cool. We're gonna know which implant works better, which drug works better, which technique works better. If you look at it, you'd say, well, we should drop implant A because implant A doesn't do as well as B or C, but not so fast. First, we should ask a very smart AI or correlation algorithm or computer or robot, show me all the cures. What do they have in common? So it goes through and it looks for every patient that had 99 or 100 on their PROs, patient-reported outcome measures. And as it turns out, 2% of the people who had implant A were cured. What do they have in common? Maybe it's that you need to receive implant A and be on vitamin B12. That's the cure. The human brain can't figure this out. We cannot sift through enough data fast enough to be able to tell this. But a computer that is actually fed outcome data plus the electronic medical record data and confounding factor data can figure this out. You talk to any oncologist, they'll tell you they don't know why one patient's cured and the next one's not. They'll also tell you that they believe if they could pool their knowledge with every other oncologist who does the same types of treatments, that they could cure their diseases. And that's it. So I can take questions.
Hey, I'm a fan of your software, and I'm glad that you actually talked about clinical chart review. So my question is kind of a big one. Based on what you just talked about, are we seeing the death of randomized controlled trials in this country?
Yeah, no. So,
because what you talk about seems to be so much more robust just based on that last sample.
it is more robust and it's more real time. But if you think about this, so I'm a doctor and I'm getting crappy outcomes and I can now see it for the first time. You'd be shocked. And am I a good orthopedic surgeon? I don't know, first of all. If I don't track my results, I really don't know. If I mess up your knee, you'll go see someone else and I'll think you did great, right? So now for the first time, and maybe I'm good at ACLs and I'm terrible at rotator cuff repair. So am I good? I don't know. So you come to see me and I can see now that I'm terrible at rotator cuff repair. So I want to get better at rotator cuff repair. So I need to read some other doctor's description of what they're doing, and I need to believe that that doctor is getting good outcomes, right? So now if there's a way for me to know that this other doctor got good outcomes measured the same way that these things are measuring them, and by a third party like OutcomeMD, this company, right? Now for the first time, I'm gonna read that doctor's study, and I'm gonna do exactly what they did because I believe their outcome, and I know that mine isn't good. So what's important in the medical literature is that we're describing what techniques we did and sharing it with the world so that, and then we can objectively say, here's our outcomes, and we didn't even track it. We had this third-party software. So this is all legitimate. Because right now, Neil Elatraj is a shoulder surgeon down the street, and if I read a study, I'll throw it out. And I'm like, he's paid by Arthrex, right? But if I see that I stink, and I see that Neil's using OutcomeMD, I'm like, I'm gonna do exactly what he's doing, because he's figured out how to get good outcomes. So the medical literature still has a very significant place in doctors explaining what they're doing differently that's getting them the best outcome, so that we can all elevate our game.
So, and quickly, from a patient perspective, and one of the things that when you and I met years ago that I liked about your software is that it doesn't do percentages or whatever algorithms. It looks at like a credit score. I went from 50 to 78, and people understand that because they understand what their credit score is. Do you think that's why your thing has such good value?
Yeah, I mean, I just think that prior attempts at outcome tracking have not engaged the patient or the provider. We still calculate the raw data, so it's all right there, and you can use it for your clinical studies. But the PROMIS is an example of a patient-reported outcome system, and they use theta values. So a negative 0.562 theta value is useful to nobody but a researcher. So we just basically take it and normalize an average and do a little bit of math, but it's still a representation of the raw score. And now all of a sudden it's interesting and understandable to a patient. And we do what the International Consortium of Health Outcome Measures does, in that we create these sets and bundles, because sometimes it takes more than one patient-reported outcome measure to get a condition score. And we're their only technology partner of ISHCOM. Go ahead.
Have you seen or done any work in comparative effectiveness, particularly? It seems to me that what we have in a lot of, particularly the specialty drug areas, enlarging pipelines. And so you have, 20 different psoriasis products. If I'm looking at that as a practitioner, I have no idea what to use. And of course, this is one of to me, the biggest failing of the Affordable Care Act is that they removed the comparative effectiveness requirement because the drug companies are not going to do the studies they can't afford to lose.
Yeah.
So have you done any of that sort of stuff?
Well, so the providers are going to be able to, the provider now wants to get a good outcome. So they're going to try to figure out which one is the best and then use that one, right? And before this, you don't really care about getting a great outcome. You need to get a good outcome and tell good jokes, right? And if you tell good jokes and you're on time and you waive copays and the lighting in the office is good and the parking is great, you're going to get good reviews and you have a sound business. You don't need to get great results. You just need to get pretty good. Patients don't know. They figure anyone would have given me a 70% good shoulder. The guy's so great, go to him, So I do think the best is going to rise to the top in the end as we really start to measure this stuff.
But
and
the
then,
insurance companies are going to make decisions based on the data, and that will drive some of the utilization by providers.
insurance companies have a big part in this, for sure. But in the end, the insurance company is aligned with the patient to some extent, and that is, if the patient gets the best treatment the first time, right? They get that treatment for psoriasis and it's the right one. They don't buy 3 other drugs. They don't have to buy stuff for their skin. They're not seeing 12 doctors. They saw one doctor, got the best of the best. It's working well. They move on, right? So, this data is just as valuable to them, and they want this to work as much as anyone.
Hi, great talk. Yeah, your software is pretty amazing. And so Barry and I will be on the health equity panel, and we'll talk about data sharing. I think you have awesome machine learning data, as you showed earlier, right? The 30,000 patients. If you would de-identify it and archive it on Kaggle, right? You'd give that access to scientists around the world, and it'd be good branding for your company because your technology is pretty amazing.
Yeah, I mean, the future is going to be about figuring out ways to cure disease and shift our models into something that makes more sense. And eventually, like I said, it's only an art of medicine because there's not enough data. So let's be scientific.
Thank you so much, Justin, for sharing your thought-provoking ideas with us. And of course, guys, be sure to stop by the OutcomeMD booth and check them out.